This is a talk, though, that I gave last year about poker and emergency medicine. So I think many of you guys know that before I came to Miami, I used to work in Las Vegas. And when I lived in Las Vegas, I played a lot of poker. And as I was playing a lot of poker and I was practicing emergency medicine, I realized something, which was that the skills that I was developing playing poker and the skills that I was developing playing emergency medicine were complementing each other. And I felt like I was better at emergency medicine because of my poker skills, and I was better at poker because of my emergency medicine skills. So what I'm going to do today is teach you some very basic things about poker and how they relate to emergency medicine, and hopefully that will make your approach to emergency medicine a little bit better. So we start with a medical case. This is a 20-year-old male who comes in with cough, fever, and myalgias for 48 hours. It's the winter time, and he has a positive rapid flu test. Whenever you are approached with a situation where you must decide whether or not to give a medicine, such as oseltamivir, as this patient has influenza, you need to consider the risks and benefits of the medicine. So here the patient has influenza, and so what are the risks and benefits of oseltamivir? Anyone know the benefits of oseltamivir? It decreases the symptom duration by less than 1 day, or according to this Cochrane review, it decreases symptoms by approximately 17 hours. So those are the benefits, and that's what the randomized controlled trials say. If you look at some of the retrospective studies, they show some stronger things like decrease in hospitalizations or mortality. But let's be clear, randomized trials show no decrease in hospitalization, no decrease in mortality, or any major complications. Only benefit seen in randomized trials is a decrease in symptom duration. So that's the benefit of oseltamivir. The risks, there are several, but the most common is GI distress, or specifically vomiting. And NNH here stands for the number needed to harm. So if you treat 20 people with oseltamivir versus placebo, you cause vomiting. It seems more than that in my experience. However, I have probably a sample, that's what the data shows. The thing that's not talked about that frequently, actually more concerning, are the neuropsychiatric effects associated with oseltamivir. In the United States, you hear almost nothing about this. But in Japan, it is actually contraindicated to give oseltamivir to a teenager. And the reason is that they had 2 suicides that they directly attributed to oseltamivir use. And in randomized trials, it does pan out that neuropsychiatric symptoms are more common in oseltamivir than placebo, with a number needed to harm of 94. So what does neuropsychiatric symptoms mean in general? It means huge mood swings, suicidality, delirium, hallucinations, things that are all worse than the flu. Okay? So when you are considering whether or not to give this person oseltamivir, one, you got your benefit, which is minimal. And remember, that benefit is also only if the medicine started within 48 hours. We're saying the symptoms have already been going on 48 hours, so it'd be like right at the border. So it's probably less even than that 17-hour reduction. And then you have some substantial side effects. So assuming that this patient is pretty stable and doesn't appear toxic or anything like that, it is my judgment based upon the risks and benefits that you probably should not give this patient oseltamivir. All right? So see how we've gone through that systematically using evidence, using some statistics? Good. So I say no oseltamivir. Second case is a poker case. All right, so you are playing a no-limit Texas Hold'em game. It's okay if you don't understand poker. You'll get this, okay? You're playing no-limit Texas Hold'em poker. In this game, you are dealt 2 cards. These are your 2 cards. In this game, you are subsequently going to see 5 common cards. So 5 common cards, 2 personal cards. All right, so your 2 personal cards are a queen and jack of diamonds. The first 3 common cards come out. They are a 4 of diamonds, a 2 of diamonds, and a king of spades. The person in front of you bets $5, which puts $15 total in the pot. You have 3 options in poker. You can fold. That means you get out of the hand. You can call. That means if they put in $5, you have to put in $5. Third option is you can raise. So you want to put in even more than $5. So the question is, what do you do here? Raise. Okay. So just as with deciding whether or not to prescribe oseltamivir, what we do is we look at the numbers, we look at the evidence, we look at the logic, statistics, and make a decision. So here's how you do this statistically, okay? First, you have to know, if you're going to win this hand, what do you need? Well, you're going to probably have to make some assumptions here. The assumption is probably that the person has at least a pair. They probably are going to have a king. It's likely that someone here is going to have a king. So what you need is to have a hand better than a pair of kings. Right now, you have nothing. You don't have even a pair. But if of the next two common cards, one of them is a diamond, then you have a flush. So what you need, making a couple of assumptions, is to know what is the chance of one of the next two cards being a diamond giving you a flush. Turns out that chance is 34.5%. So there's a couple or a few common things in poker that if you play it a lot, you should memorize the percentage chances, and this is one of them because this comes up a lot. So 34.5% chance of getting a flush if you play this to the end. If you convert that to odds against, that's 1.9 to 1. It's okay if you don't follow this math, just bear with me. And the other thing that you need to know is what are the pot odds. Pot odds is just the ratio of money you can win to the money you have to put in. So you can make $15 by putting in $5. So the pot odds here are 3 to 1. So the way that you decide if this is a statistically correct play to continue in this hand is you compare your pot odds to your odds against hitting the hand. If the pot odds exceed, meaning that the correct play here is either to call or to raise, but it is definitely wrong to fold. If you folded this hand, you would be playing this hand incorrectly. Now, it's okay if you didn't follow all of that, but what the point of this is that in both cases, I'm having to make some assumptions. I don't have 100% of the data to be able to definitively calculate what is really the best option, but I use the best available evidence and statistics that I have. I weigh the risks and benefits, and then I make my decision based upon that. If you don't think that that really explains how emergency medicine and poker are related, let me go one step further. So I'm going to go through 4 tenets of poker that are just like in emergency medicine. Here's number 1. Number 1, it's rare to get the nuts. Anybody know what the nuts are? Nuts. The nuts in poker means the best possible hand. You say, I've got the nuts means I've got the best possible hand for that given hand. This hand shown here, if this is a no-limit Texas Hold'em game, then this is a royal flush. Ace, king, queen, jack, 10, all of hearts. That's a royal flush, hand I've never had. So the point of this here is that getting the best possible hand is actually very rare. I'll go and play for a few hours and maybe if I'm lucky have the nuts one single time, playing dozens, maybe 100 hands. It is rare. Similarly, in emergency medicine, it is rare to have that complete certainty that what you are going to diagnose that patient with or treat that patient with is correct. So when I think of what is the nuts, where am I completely certain that I've got this right in emergency medicine, I think about appendicitis, where I've got a CT scan. I think of a young 20-year-old guy who's got periumbilical pain, it radiates to the right lower quadrant. I get a CT, and the radiologist reads, consistent with appendicitis. You're going to diagnose that patient with appendicitis, correct? In the clinical impression, you're going to put appendicitis, and you're going to feel good about that. You're going to call surgery, you're going to say that's appendicitis. And most of the time, 99 probably % plus of the time, you are right. But guess what? Even in that case, you're not 100% of the time right. Because I've seen that case. I've seen that exact case where the kid didn't have appendicitis despite the perfect clinical presentation and the CT that was read as appendicitis. He had a cancer. He had a cancer on op report. which means that what you really need to understand is that there's very little certainty that you are correct. Very rare cases where you're 100% certain that something is going on, and you should respect that both in poker and in emergency medicine. Treatment is even more random and more of a gamble. So there are so many factors to consider in whether or not who should get a certain treatment. But things where the mainstream media would have you that we should be giving all these strokes TPA, we all understand how much of a gamble giving TPA really is. Have somebody with some mild deficit, and you can give them medicine that could cause a life-threatening intracranial hemorrhage and kill them. Not so simple. Not certain. Tenet number 2 sort of follows from tenet number 1, which is that everyone will have a bad beat. Bad beat in poker is just a term for really bad luck. So you just had a hand that probably should have won, but the other person got lucky. You've hit a bad beat. Example in poker, this guy in the white shirt, he has an ace 10, and so he has 2 pair because there's a 10 and an ace on the board. He's playing against somebody who has only 1 pair, just an ace, and that queen does really nothing for him at this point. So the ESPN has calculated here that Gil has a 93% chance of winning. He's looking pretty confident at this point. I think you know where this is going, though. This is a slide that says everyone will have a bad beat. And so, unfortunately, there was only 1 card that could have won this hand and lost it for Gil, but that one hand, or that 1 card, which is the queen, happened to be the last card that came out. So despite a 93% chance of winning, lost thousands of dollars in a very, very bad beat. If you haven't had your bad beat yet in emergency medicine, you will. And if you have a long career, you're going to have a whole bunch of bad beats. You really can't do much, unfortunately, to prevent a bad beat, but we'll get into that again more in the next slide. There was a study published in Annals of Emergency Medicine 2018, and it looked at a whole bunch of factors associated with lawsuits in emergency medicine. And there were only 2 things that were found to actually be strongly associated with getting sued. And they were the number of years that you practice emergency medicine and the number of patients that you see. Which basically means the only way to prevent a lawsuit is to cut your career short. Probably not something that you want to do or should think about when you're a resident. Maybe a little, maybe when you're mid-career attending or something. But anyways, the point here being that getting sued is basically just a bad beat. In many cases, there is nothing that you could do about it at all. But now you're feeling depressed. You're like, I'm going to get sued, and there's nothing that there's nothing that you could have done to prevent that. Well, the good news is there is something that you can do to put the odds in your favor. And that is to use, in poker, the statistics, in medicine, the evidence/statistics. So I saw Boris out this weekend, and he was wearing this I Love Evidence-Based Medicine shirt, so I decided to take his picture, include it into this talk. But if you miss something, and you, for example, a head injury patient, and you used the Canadian head CT rules, and you used it correctly, and you documented that you used it, but the patient has a head bleed and died, and someone looks back at your chart, what were you supposed to do, though? You used a validated clinical decision rule. You said why you used it. That is a very tough chart for someone to say that you've made an error on. All right, so if you follow the evidence, if you follow the statistics and something still happens to you, you are protected as well as you could be protected. Nothing protects you perfectly, but that is very strong protection. In poker, I used to get really upset when I would have terrible bad beats. When I would have a really good hand, I'd play it perfectly, and then the other person would get some ridiculously lucky play and take a lot of my money. And I'd be pissed off, but now, partially because I have more money, partially just because I've gotten used to it, I realize that that's just part of the game. Bad beats, just part of emergency medicine, and just part of poker. As long as you're playing it correctly, I'm following the correct statistical play in poker, I'm following the evidence in emergency medicine, sometimes it's going to happen no matter what you do. So you do your best, but no matter what, you can hit that bad beat. The last tenet, art can trump science. So unfortunately, you can't follow evidence-based medicine for every part of your practice. There doesn't exist enough evidence to do so. So you have to have something else, may it experience or Gestalt, whatever it is. You need something more. And plus, we all know that there's a lot of people out there who know a lot, have great book knowledge, know the evidence well, but you've worked with them and they're not necessarily the best physician. There's something else other than just that statistical evidence knowledge that makes someone a good physician, especially an emergency physician. Poker example, this guy here, his name's Phil Ivey. He's won at least 10 World Series of Poker championships. There are so many people who understand the statistics of poker, yet this guy consistently wins. How does he do it? You'll have to ask him. But he's got that it factor, and that is why you need a residency. You need to find your mentor who you see, this is the person who has that something else. So those are the tenets of poker and emergency medicine. And just to conclude, I'll say the following things. Number one, there is a ton of uncertainty in emergency medicine and poker. You can let it drive you crazy. You can let fear drive your practice, or you can embrace it, understand that's just part of the game. And you can use the available evidence, the available statistics to help guide your decision making and become better. That's it. Thanks. Beat the odds.